and term infants. And as you know, as you realize, the younger you are, the more protein per gram per kilo per day you need. Now this number is still not clearly defined, and many people around the world are using up to 4 grams per kilo per day of intravenous protein in their very preterm infants. I'm still not sure if that's too high an intake for these infants, and there are a lot of concerns being raised now, and not with very good science, but just anecdotal stories, that some of these babies are on very high amino acid intakes, may have increased rates of cholestasis or cholestatic liver disease. So we really need to work on defining what's a safe upper limit. So just briefly, I want to talk about, is BUN an appropriate marker for determining protein intolerance? And I get asked this probably more than any other question. So blood urea nitrogen may increase when given protein is not completely used by the body. And so we call this bad BUN. That's just sort of our term. Nobody else uses that term. However, urea production may also be a byproduct of amino acid oxidation. In other words, amino acids that are given can be used as an energy source. And if you're not getting enough energy for other sources, this may be a good source of amino acids, and we call that good BUN. So keep in mind that the fetus takes up amino acids from the placenta, and that the amount of amino acids taken up greatly exceed the amount that's needed for this fetus to grow. And excess fetal amino acids can be used as an energy source, in other words, oxidation. So it's estimated that 25 to 50% of energy in the fetal sheep comes from oxidation of amino acids, and there's data from animal and human studies that show the normal fetus produces BUN at a high level and doesn't appear to get toxic from it. So these data would suggest that the fetus can actually use amino acids for growth and as a significant energy source. I just want to talk about a couple of other aspects in our studies, that there's evidence that very preterm infants who don't tolerate glucose and lipids, so in other words, they develop high serum glucose and triglyceride levels, even when they're getting very low glucose and lipid intakes, these infants can probably use amino acids as an energy source. And in this case, if they're using amino acids as an energy source because they're not getting it sufficient amounts from other sources, elevated BUN may actually reflect a beneficial use of amino acids for energy and not protein intolerance. The problem is, in any given baby you're taking care of, you can't tell if if a BUN level is good BUN or bad BUN. But hopefully that can be sorted out over time. And I just want to show you briefly, we went back and looked at all our patients who had blood BUN levels over a number of years. And this slide shows the correlation or lack of correlation between amino acid intake, 0 up to 4 grams per kilo per day, and BUN. So the role of BUN, which most people use, I think is still not well defined. Okay, so the American Academy of Pediatrics guidelines for feeding the preterm infant have the goal of providing nutrition that will duplicate the in utero growth rate and body composition of the fetus at the same gestational age, while maintaining normal concentrations of blood and tissue nutrients. I'm not exactly sure what that means, but there have been very little guidance by the AAP as to how to accomplish this. And so we are currently doing a study, and we're studying whether the provision of fetal nutrition, estimating what the fetus would get at that gestational age, and those rates to preterm infants, if we give that amount of nutrition to the same preterm infant of the same gestational age after birth, will they be able to achieve those AAP guidelines of growing like the fetus? And this is where Eckhart has been very helpful, and he's done a lot of the work that has really estimated what babies who've died at different gestational ages, what their body composition might be. And knowing that body composition, then you can then look back and say, if the fetus was growing like that, what nutrients must it have gotten in utero? So from his work over those years, he's been able to provide some data on which we can then do this type of a study. And I'm bringing up this slide because yesterday the question came, what growth charts do people use? And I think if you're trying to find a growth chart for your practice, what you really need to do is look at the kind of patients you have. Dr. Hoyos, for example, said, we use growth charts that would be more applicable to babies who are somewhat growth retarded because we see growth retardation at this altitude. For my studies, I have been using this curve combined with Eckhart's data, infants that are growing at the 50th percentile who are quite preterm and at the 10th percentile. So for my studies, looking at can we get the fetus to grow like the preterm infant to grow like the fetus at the same gestational age, we're trying to get babies to grow along these curves right here. But I think what you have to do, this is an aside, to try and determine what growth chart you should use, you really need to look at your population and then try to find published growth curves that would maybe reflect more what your practice is like and what you see. There's the NICHD and the CDC are developing growth curves, international growth curves, that might turn out to be applicable for almost any population. So this is just a brief look at this, and I hope it's right, Eckhart. I hope you're not going to quiz me on this. But for example, for that last growth curve of babies growing at the 50th percentile, we look at them by gestational age and approximate weight. And from these two categories, then we decide how much nutrition to give them. So for example, at 24 to 26 weeks gestation and approximately 625 to 849 grams, the rate of fetal weight gain in grams per kilo per day is 21 grams per kilo per day as an estimate. And as you get older and bigger, that rate of weight gain goes down per kilo per day. So how much protein and carbohydrate and lipid do we need to give to get the babies to grow like that? So this bar represents protein intake required to grow at the fetal rate, and these babies get this amount when they're in this age group. If we, this is a protein intake, this is intravenous and this is oral, and so orally you get more protein than we would give intravenously. This is energy intake, combined protein or lipid and carbohydrate in the intake they get, and this is what they'd get if they were giving the same energy orally. The question came up yesterday of, do we give 4 grams per kilo per day of protein to babies on IV nutrition? So really, we give them 3.5 grams per kilo per day, because if you give it intravenously, ideally you should be absorbing and utilizing every bit of protein you get. Whereas if you're orally fed or enterally fed, a lot of the protein you take in won't necessarily be digested completely and will be passed out in the stool. So 4 grams per kilo per day, that number of protein intake really applies to enterally fed babies, and it's probably a lower number for parenterally fed infants. And then here's just similar data that we're using for the infants growing at the 10th percentile. And again, we do the calculations, and every day when a baby comes into our unit, from the first day of life, we give them this nutrient intakes. We follow it every day. If they don't get what was ordered, we make it up in the next several days. These babies are followed from birth till hospital discharge. We measure the breast milk content. We try fortify that if it's getting behind. So we're trying to give the fetus what we think, or these infants, what we think the fetus gets. Okay, so now this is a talk on both enteral and parenteral nutrition. Why do we need to talk about them together? So even though there have been a lot of advances in early aggressive parenteral nutrition, because of associated complications like cholestasis and other things, parenteral nutrition should generally be considered a very short-term strategy unless you have a baby with problems that necessitates long-term intravenous nutrition. And it is unlikely that, at least for the American Academy of Pediatrics, the guidelines will be achieved without including evidence-based strategies for early aggressive enteral nutrition at the same time. Now, so this surprised me. If you go back and look at early aggressive nutrition approaches for combined parenteral and enteral nutrition, there have only been 3 studies that have ever been done on this topic. And best is by Paul's. I think that was done in 1988, and these are the two other studies. But his was the largest study. And he randomized 125 very sick preterm infants back in the 1990s, and he had an aggressive feeding group and a control group. And amino acids, he started on day 1, lipids day 2, and kept increasing these. Minimal enteral feeding started at day 1. With the control group, there was less intake of either of these nutrients, and they both increased more slowly, and they didn't give any enteral feedings until stable, whereas he was giving minimal enteral feedings from day 1. So in the 1990s, nobody else was even really thinking about these issues in this way. And there's a lot of work that really needs to be done on optimal combined enteral and parenteral nutrition. They should complement each other. So early aggressive parenteral plus enteral intake resulted in shorter time to regain birth weight, improved growth at hospital discharge. Unfortunately, very few people have even tried to redo this kind of study. And again, I think it's a fertile area for research. One of the things that several people have asked me since I've gotten here is how do you get started with your TPN right away? Many units have to send out or order out for parenteral nutrition, and because it takes a few days to get back, babies don't get started on protein for several days. So many people are using, and this is just an example I want to give you, something called stock or starter amino acid solutions. And when you're giving these solutions, you want to look at the percent amino acids you're giving. You want to look at the fluid rate, and then you want to look at how much amino acid you're actually going to end up giving. So for example, in a baby, many people fluid restricts babies with chronic lung disease and keep them for days at 16 mLs per kilo per day to avoid worsening chronic lung disease. So if you give 2% amino acids and 10% glucose at 60 mLs per kilo per day, you'll be giving the baby this much amino